Hey guys, my name is Seth Thomas. I'm a student physical therapist assistant from Jeff State, and today I'll be working with a patient who recently had a total knee arthroplasty. Right now she's 4 days post-op. She is 59 years old. She's female, and right now she is weight bearing as tolerated. Past medical history is pretty much unremarkable, but she does mention that the right knee for the past 2 to 3 years has had osteoarthritis more so than the left. Both of them have it, just the right knee. She basically couldn't take the pain anymore. Felt like she wanted to put her knees across railroad tracks and have a train run over them. So she's at the point where she just needed a new knee. So basically the new knee, the distal part of the femur and the proximal part of the tibia has a polyethylene or metal-backed makeup that makes up the new joint. So instead of articular cartilage, which is basically gone from the osteoarthritis, they put a whole new knee segment in right there, so it articulates. So she needs some rehab to get that thing moving. So some subjective comments she's mentioned. She complains of symptoms with weight bearing, less than 5 minutes sit to stand, and sitting with knee flexion. Right now her primary goals are gardening, so she wants to be able to squat down, and going up and down stairs independently. She's having trouble with that, which is pretty common with a total knee arthroplasty. Just a few objective measurements. Decreased range of motion. I'll go over the exact measurements here in a little bit, but right knee shows signs of inflammation, edema, and the quad, which we'll talk about later, did an exercise for that, is showing some signs of poor VMO contraction and just some weakness. Alright, and we're going to do joint mob in just a sec. Alright guys, joint mob time. So our patient presents with decreased range of motion, flexion, and extension. The measurements we got from the objective measurement: active range of motion, right, is lacking 15 degrees of extension and only has 70 degrees of flexion. And his left, we kind of base it off the left side, what's normal for the patient. 0 degrees on extension, so they've got full extension, and the flexion is 135. So we're lacking about 65 degrees of flexion, so limited in both ranges. So we're going to do a joint mob to address both of those. So the joint mob we're going to do, I'm going to show you with our patient Steven as our demo guy. We're going to do right tibia, femur, anterior, and posterior glides 3 and 4. The patient tolerated grades 3 and 4 in the initial eval, so we know we can do that here to try to improve some range of motion. So we're going to show posterior right tibia femur glide. So we're going to bend it up to in range as far as the patient can take it. So we got about 70 active passively. He got about 75. So we're just going to take that to its in range. Okay. Stabilize. Just going to sit on the foot. Alright, and we're going to place our hands on the tibia, basically where the tuberosity is, just under it, and hands underneath, and thumbs anterior. You're going in a downward glide, and you're going grade 3 and 4, and when you get there you're just going to oscillate back and forth, checking with the patient to make sure it's alright. We'll do about 5 minutes of that, and we'll switch, and I'll show you. This is improving flexion. So we took him to in range. This is as far as Steven could take it in this range, and we're going to switch and try improving extension. Alright? So we'll just have Steven roll over on his stomach. So he's lacking 15 degrees of extension. So we place a little towel underneath the knee for comfort. Alright, stabilize. And I forgot to mention what I was doing earlier. I was distracting as well. So you want to pull back a little bit just to get a little separation on the joint so you can do a glide. So I'm going to stabilize. His knee's stabilized here, and I'm distracting a little bit. And I'm grabbing the back of the tibia posteriorly, and I'm going to go in an anterior direction. I'm going to get to grade 3 and 4, just oscillating back and forth. It's patient education. So if you will, take a look at Steven right here. So one of the key things initially, this patient, like I said, is 4 days post-op. What they can do at home after doing a little, exercises, they can do. They want to make sure they're icing, and with ice, you want to have elevation and you want to be resting. So we've got a wedge here in the clinic, in most clinics, right? But not all patients will have that. So what you can do at home, I've got, 4 pillows here, and you just want to make sure the knee is extended. You don't want them in a relaxed position, because then that'll increase stiffness and decrease range of motion. So you kind of want to, you can use a little towel roll underneath the ankle just to make sure the knee is straight as it can get, and just have it elevated above the heart. And with the ice pack, you don't know how to do it, but just to refresh, using towels, you'll have a moist one. Go over the knee. Always check the skin, knee for sensation. You feel that? Yeah. Good? Awesome. Of course, I'll be doing this at home, so check your own knee. Then we'll have, a damp one, pillowcase, is our ice pack, and then a dry towel, just to keep that from, the condensation from leaving. So try to keep the cold in, basically. All right, we'll do that for about 15 minutes, and just remind the patient to check it every 5. Just make sure, C-band's going on and no skin irritations happening. I'm going to tell you one of the most important things that you can do for your patient as far as a home exercise is concerned. So, as mentioned in the initial eval, the patient presented with poor VMO and poor, quad contraction, basically. So the quad is essential. Strengthening that after a total knee and any kind of knee procedure, you just want to get that as strong as possible, because with gait, after a knee arthroplasty, they're going to have decreased stance time, like our patient has, decreased stride length, because the quad, it controls the amount of knee flexion during initial contact and then extends the knee toward mid-stance. It gains control of the amount of flexion during pre-swing and prevents excessive heel rise during initial swing. So pretty important with gait. So after a surgery like that, most patients, unless they're 20 Olympic athlete, they're going to have a pretty decreased, atrophy in the muscle at the quad. So it's real simple. You tell your patient, all right, Mr. Albany, and they're probably going to be elevated because he does have 15. He's got his range of motion is a little decreased. So initially, I like to have a pillow underneath, and I like to have the patient. You can use their hand and just relax. And I want you to push your knee down into the pillow. You feel that quad tighten up? Yes. So you have some biofeedback right there, letting them know that, yes, I am contracting the quad. Hold for about 5 seconds and relax. It's one of the safest things you can do. And I tell the patient to do about 3 sets of 10, twice a day on non-treatment days. In the case of my patient, she's 58 or 59, I can't remember. But she might have some back issues with that. So at home, get some pillows. Do it for me. We use this wedge instead of pillows, but we can use those pillows just the same. And have her lay back, protecting the back, and we're exercising. Alright? Pretty simple. Prognosis. The patient's going to ask, how long is this going to take? According to our patient after the re-eval, and she doesn't really have any comorbidities, rehab potential is looking great, and I would tell her, there's a great chance of you getting back to the things you love to doing, like gardening, being able to squat down, walk independently, and going upstairs independently. Based on her rehab, her re-eval, it looks great for that. Activities may take a little bit more time, and you might need to have a cane initially until you kind of wean off of it, and that right leg gets a little bit stronger and more range of motion in it. The estimated time frame of rehab is normally 6 to 8 weeks that she'll be in here. Could be longer, could be shorter. My patient will probably be shorter based on how well she's doing. She's going to continue rehab at home, strengthening that leg, getting it more range of motion, and that could last anywhere from 3 to 6 months, patient dependent. Progression of my patient to the next level will be hopefully 2 more weeks to where she's cane free based on how she was doing. She still struggles with stairs and walking distances longer than 1,000 feet with the cane. So the goal for the next 2 weeks is no symptoms with stairs or gait, and eventually we'll without the cane altogether. Needless to say, my patient's rehab potential looks great. Alright guys, that's it for me. If you have any questions, just let me know. Thanks.